Thank you for joining the American Association of Kidney Patients for our 45th annual National Patient Meeting. My name is Edward Drake II. I was an active 20-year-old at the height of my athletic and college career when my life dramatically changed. During a routine physical, the doctors were so alarmed by my dangerously high blood pressure that I was immediately rushed to the emergency room. I went from the football field and college campus to the hospital bed overnight, and I was soon diagnosed with kidney failure. I began dialysis in 2006, which I did for 2.5 years prior to receiving my kidney transplant on October 8th of 2008. I received that life-saving kidney, and soon after that started an organization called Why Not, which is an acronym for Youth Needing Organ and Tissue Transplants that provides support for pediatric transplant patients and promotes health prevention and wellness in the community. I'm honored to be a national ambassador for the AAKP, which has allowed me to connect with other transplant patients across the country and utilize my voice, experience, and platform to impact lives. It's my pleasure to introduce our speaker, Dr. Benedetti. Dr. Benedetti is a transplant surgeon at University of Illinois Health, as well as a professor and head of surgery, and the Warren H. Cole Chair in Surgery. He is a prominent leader in organ transplantation and in the use of robotic assistant techniques in transplantation. We are pleased to have Dr. Benedetti with us to discuss his research on muscle contraction therapy. It is now my pleasure to welcome Dr. Benedetti.
Good morning, and thank you so much for the invitation. It's an honor to participate, and I think you will be interested in what we have done for our patient, both before and after transplant, in terms of strengthening their condition. So the cycle of life is actually what's happened to our muscle. The muscle will grow as you reach the young age and peak around the age 22 to 25. And then as you advance in age, is a physiological process that our lean mass decrease. For example, this is a CT scan of the same individual taken at age 25 that show the full strength and fullness of the muscle fibers compared to the same individual at age 63. You can see that there is fibrosis, the muscle mass is less. So it's a normal process of aging. These graphics show what's happened. The muscle mass grow until peaking around age 22. And then there are two ways to decline. You can have a normal decline, which is unavoidable but slow, or you can have a rapid decline, either because of lack of exercise, malnutrition, medical problem, associated morbidity, consequence of surgery. In that case, the decline of the muscle is more rapid, and you may actually reach a threshold in which your life is at risk beside your function. Multiple studies have shown that poor musculoskeletal health increases the risk of mortality independent of age. This is a very large study published in Europe and was a prospective osteoporosis study. You can tell that in different settings, sarcopenia, the lack of muscle mass, the decline of our lean mass, is associated with mortality. For example, in the paper for elderly patients with a fracture of the femur or patient after trauma, you can predict the mortality based on the muscle mass. Or cancer patient, you can predict the mortality or conversely the survival in patients with hepatocellular carcinoma based on the presence of sarcopenia. In the patient population that is a candidate for kidney transplant, actually frailty is quite prevalent. A study from Dr. Sejev from Johns Hopkins published in 2015 showed that about 20% of the patient at the time of kidney transplant should be considered frail. It's a medical definition. Being frail has an important repercussion in the patient survival. In fact, at 1 year, frail patient had an increased mortality of fivefold, 5.7 versus 1.6. At 5 years, the difference is even more spectacular. The mortality in frail patient is 22, while the mortality in patient with normal muscle mass, non-frail, is only 8. Again, more than almost triple mortality. We decided to try to address this problem that if you do kidney transplantation like I did for over 30 years is pretty clear by introducing a very interesting original method that I designed as GH from the initial of its creator. Is a special exercise rehabilitation program, low impact, designed to actually train without intense fatigue, even patients that are highly deconditioned. It's an interesting program that works even on the extreme. For example, has been very successful in reestablishing muscular health and avoidance of pain in professional National Football League players, such as Kit Van Orde, that is a local idol in Chicago, as member of the winning team of the Bear. So we decided to actually start a randomized trial in kidney transplant patients between 18 and 65 years. All of them had successful kidney transplant, and they were in the minimal condition to be able to participate with the exercise program. We didn't look for athletes. Most of the patients were with modest ability to do exercise, in fact. The patients were randomized to be compared with the standard medical therapy. And we actually did the training for a period of 1 year, 52 weeks. The patients were randomized for a set ratio of 2:1 to either GH exercise, twice a week, 1 hour, 1:1 with the trainer, versus control, that simply were following standard medical therapy. We had several drops, mostly due to logistic, but 85 patients complete the program, and that will be the subject of my presentation. So we will do the review of the outcomes of these 41 patients that complete the 12 months randomized control trial. And we will focus not only on their achievement in the realm of strength, but also the ability to find employment or return to school after kidney transplant. This is the final number of patients. 41 complete 2 days a week exercise rehabilitation program for 1 year, where 25 patients constitute the control group. Both groups were tested formally at baseline 6 months and 12 months. Of course, we also assess their employment status and school status. These initial slides show actually the exercise capacity of the treated patient. Pretty much, it's a very precise amount of their total exercise capacity. Is done by multiply the number of repetitions with the pounds of the weight that they move. The exercise is based on weight training. And you can tell that the beginning, the average amount of pounds lifted per week was 4,600, which were triple at 6 months to 1,200, and end up at 16,000, I apologize, at 12 months, constituting a 4-fold increase of their ability to lift weight. Again, this initial report compare now control with exercise. The peak strength, leg extension went up significantly. We measured the bone mineral content with scan, and there was a significant increase of bone mineral content at 12 months, comparing the exercise group to the control, we decrease significant the level of pain interfering with daily activities in the exercise group, and the pain remains stable with no change in the control group. This is a very important factor because decrease of pain has important ramification in the realm of mood, depression, ability to find a gainful employment. You can tell that the patient tested at baseline 6 months and 12 months on the global physical LT score had a significant improvement, statistically significant, on the exercise group with static finding on the control. The global mental health score, again, spectacular improvement, while for the control patient, if anything, it declined. And again, is a significant, statistically significant difference. The perceived physical function T score improved on the exercise group. But I believe the most striking result has been the employment status. 55% of the patients undergoing the exercise program that were not employed at the time of the enrollment found a job, versus only 10% of the control. This is a clearly highly statistically significant difference. This is an impressive number because we previously published on a database to find a very high rate of unemployment after kidney transplantation. On UNOS database, out of 46,000 patients that were not working at the time of transplant, alive with stable renal function 1 year post-transplant, only 5 to 6% found a job with heavy reliance on public aid. And most of the patients report a feeling of disability, the reason why they didn't seek job or maybe they didn't obtain job. Again, the patient that underwent this training returned to the workforce 55% of the time. Of course, once we establish such a favorable outcome in our transplant patient, we start wondering if we could do something for the dialysis patient. In a way, try to maximize the function of this patient before they go to transplant. Dialysis is known to be one of the major risk factors for muscle atrophy and lower functional capacity. And of course, this directly predicts increased risk of cardiovascular complication. As chronic kidney disease progresses, skeletal and muscle dysfunction progresses as well, leading to mobility limitation, loss of independence, depression, vulnerability. Both reduced cardiovascular capacity and depression have been identified as risk factors of mortality in this population. So, no doubt there is a need to intervene in dialysis patients, maybe even greater than in the post-transplant population. We start with a pilot study. We enroll 11 dialysis patients from UIC, and we actually started them in one-to-one, twice a week, personalized exercise with the GH method, the same that we use for the research I just presented. The idea was try to improve the physical and mental health of the patient to prepare them for a successful kidney transplant. We're going to share with the group the result of this pilot study. Again, this is not a randomized trial. It's just a pilot study on a group of 11 patients. Only 11 patients, we see a statistically significant self-report physical function after the 6 months compared to baseline. The short performance battery score improves statistically significant in 6 months. Pain interference T-score mark reduced, again with a statistically significant difference. And this is quite impressive because it's a short time, 6 months, and it's a small number of patients, only 11. Energy fatigue, significant difference over time with P-score less than 0.01 at 6 months. Higher score means more energy and less fatigue. Depression, again, a significant difference in the depression score as measured by the PROMIS questionnaire. At 6 months, the patients were mostly out of the range of clinical depression. General health, SF36 questionnaire, baseline versus 6 months, significant increase, statistical significant difference. This is a video of a patient testimonial that I like to share with you. And pretty much we have by IRB the authorization to actually make a movie of the patient the first day that he comes for training, and then 6 months after completion of the training. This is one of my patients that came to me almost suicidal, very depressed. I offered him to join the study, and he did. And you can see the first time that he went to see the trainer, he couldn't even stand up for more than once, was not able to walk, and he's a relatively young man of age 52, gainfully employed, father of 2. He was very depressed because clearly he could not keep up even with this simple desk job. As you can see, he had trouble even to actually sit for the training, debilitating cramps. And the first day was quite laborious. As you can see, it's difficult for the trainer even to put the patient in the exercise. We deliberately pick patients that were particularly frail. And you will see the result of the training after several months. And this man is not the exception, is the rule. We had 7 patients in similar circumstances, again unable to walk, that did a lot better after being treated. 16 weeks into the program, there is some difference in the performance. You can actually move around, and of course you can do the exercise much better. The patient is able to walk without walker, take step. Of course, he's still limping because he will need knee surgery that we actually did since then. A lot of good things happened to this patient. He underwent a successful kidney transplant. He went back to work. We helped him with the knee surgery. And now he's a stronger man. At that time, he was still on the waiting list for transplant, but he's no longer the debilitated patient that you've seen at the beginning. As you remember, he was able only to do 1 stand-up, and then he couldn't. And here he does consecutive 10 without much effort. Pretty much we transform an high-risk patient with limited mobility, limited strength, most likely to have a significant complication after transplant in the stronger man that really can take the rigor of the operation and do better. Since then, we have started a randomized trial that is aimed to enroll 150 dialysis patients We have already enrolled 41 until the COVID-19 pandemic strike, and we had to suspend. I'm happy to share that we restarted the trial 2 weeks ago. So we have a randomization again 2-to-1 in group one, the exercise group, again twice a week, personalized 1-to-1 exercise training in the day of dialysis, 6 minutes each session. And the group 2 are patients on dialysis randomized not to receive the physical treatment, the exercise. Of course, it's difficult to keep them all. We are actually paying them to continue the participation because, of course, they're quite upset not to be chosen on the exercise side. We will be able to complete the enrollment in the next 6 months and hopefully share more results with you in a year from now. Meantime, thank you for your attention. We are very excited with this program. It's really helping our patients, and we hope that many more patients will be able to use this original method to optimize their condition in the difficult setting of dialysis. Thank you.
Thank you, Dr. Benedetti, for your great presentation. Can you please tell us how your interactions with patients, hearing their stories, and witnessing the challenges they overcome has made you such a great advocate for allowing patients a greater voice and choice in their care options?
Thank you for your question. I must give credit to my patient for most I have done in my profession, in my career. I've been a surgeon for over 30 years and a transplant surgeon as long. So I've seen literally hundreds of patients before and after transplant. And I know that many of them are debilitated. And doing the kidney transplant is very satisfactory, both to the patient and to the caring physician. Still, you have the impression that you did not complete your work. In many cases, although the improved kidney function helped the patient, is not a complete rehabilitation. I have the feeling that by adding this particular program to the transplant, we really do the whole job. And I believe that the proper thing to do is to actually train patients while on dialysis, get them stronger, transplant, and train them again. And that's my goal, and that's what I'm going to try to do in the future, hopefully in a larger and larger scale.
Thank you, Dr. Benedetti, for an excellent presentation. On behalf of AAKP, we appreciate you taking the time to share your insights and expertise.